something light. Okay. All right. Pharmacologic measures, like we talked about before, they're probably going to be on ondansetron, and they might have some pain medication, so they're going to have other medications that are not going to make them want to eat or feel like doing anything, okay? All right, patient and family teaching, okay? All right, so this patient's been diagnosed with either brain cancer or laryngeal cancer, okay? You have to treat the family's emotions, right? Because this is a shock to everybody, all right? So you need to get maybe the case manager or social services on board, okay, to help them to deal with this, okay, to help them cope with it, because these might be life changes, permanent life changes, depending on what's going on. They may have permanent memory loss or some type of a physical disability. So everybody's going to be involved with these patients: PT, OT, ST, case management, social workers, okay? And they'll probably refer them to like the Brain Injuries Association if they have a brain injury, or National Stroke Association. So just remember that the families need to be involved too, and the families need to be addressed, okay? Measurable patient outcomes. What do I mean by that? Give me an example of a measurable patient outcome.
Patient will report a decrease in pain.
Yes, that's one. Very good. Okay. Or your measurable patient outcome will be, patient will eat 3 small meals today instead of 2. And then, of course, your evaluation was did they meet it or not. So you always are measuring their outcomes. Okay, you're planning an outcome for them, and then you're evaluating: are they progressing or are they not? Okay. All right. Oncologic emergencies. I'm going to talk about this. Does anybody have any questions so far? Okay.
Oh yeah, Dr. Phillips, I had one question.
Yeah.
About the ointment with radiation. Was there like a specific one, or it's just something they prescribe?
It's something they usually prescribe. But if they once they go home, if they want to put lotion on their skin, you would want to make sure that it's fragrance free, it's hypoallergenic. It's something gentle, not something perfumey or got additives in it. But usually it's like the hydrous lanolin, something that's gentle to the skin to help it to heal. Okay. But if they don't prescribe something like hydrous lanolin or something that's hypoallergenic, no perfumes or anything, fragrance free. Good question. I did have a student. Ask me yesterday. Well, what about the incentive spirometer for transphenyls? No, you're not going to have a transphenyl patient doing an incentive spirometer because their surgery is here. Does that make sense? Okay. And as soon as that packing's taken out and it starts to heal, but you can get them to do other things like repositioning or sitting them up in a chair, but they won't be doing the incentive spirometer, FYI. Okay, so then somewhere. But okay, oncologic emergencies. Now, this is not you're not going to be tested on this, but this is something that's good to know in case you're taking care of someone that has chemo in your family, or you're taking care of a patient, or anything. It's just good information to know. These emergencies can occur either from the cancer itself or from the side effect of treatment. Okay, there's 3 types of metabolic emergencies. There's the tumor lysis syndrome, and what this is. Hold on, let me get to my notes. Okay, so what tumor lysis syndrome is, it's a metabolic imbalance, okay, and it occurs as a result of high tumor cell kill. So they'll be giving a very large amount of chemo to help kill a high cell count. Okay, and what happens is, as a result, in the rapid release of normal intracellular products, is that the cells are starting to leak. Okay, so what happens when the cell starts to leak? Okay, we talked about hypercalcemia. They can get hyperphosphatemia, hyperuricemia, and hyperkalemia. Now think back to Miss Garrison's lecture. Okay, what happens when somebody's hyperkalemic? What can it cause?
EKG, rhythm strip changes.
Yes, cardiac arrhythmias. Okay, it can cause renal failure and even death. Okay, if these cells start to leak too rapidly. Okay, septic shock. Now, I know you haven't had your septic shock lecture yet, but with septic shock, they're extremely immunosuppressed, right? So they're at a higher risk for infection. Okay, and then you have your hypercalcemia, which we talked about before. Okay, so these are all things, and of course, what can happen if somebody starts getting hypercalcemic? Okay, it's usually mobilizing from the bone, and it'll exceed the renal threshold. So the kidneys will become involved. Okay, so the standard therapy for that, FYI, is they'll do vigorous hydration with normal saline and Lasix. Okay, just a little FYI to try to flush that out. So let me ask you something. You have a chemotherapy patient, okay, and they're in the hospital, okay. Can they have visitors? Are their visitors going to be limited?
Limited.
No, they don't have to limit visitors. Now, that's not going to say you're going to have 10 of them going into the room at one time, but they can have visitors. You know, they're not going to limit their visitors, okay? But what you need to assure that they're doing, the nurse as well as the visitors, before they go in that room. Yep, washing those hands. It's extremely important because these people are immunocompromised. But they can have visitors, and they don't, and unless it's something that's really specific, they don't limit their visitors. Okay, unless the visitors are really aggravating. But just like with Miss Wiggins' lecture, you know, you want to keep them. You want to make sure that when they're visiting, it's a calm environment. You know, the kids aren't jumping around and bouncing off the walls, causing them to stress out. You know, the older I get, the calmer I like to be, the quieter my environment. So yes, they can have visitors. Okay. Other type of emergencies, getting back to my emergencies, are, let me get this up here. Hematological emergencies. Okay, this is from your bone marrow suppression and your hyperleukocytosis. Okay, and idiopathic bleeding can occur and DIC can occur. Okay, so when these patients are getting, if these type of emergencies occur, like some of these chemotherapy drugs can cause chest pain. If they're at home and they're having chest pain, they need to call 911. Okay. And of course, spinal cord, if it progresses to the spinal cord, of course, not only will the ICP be affected, but they can, brain herniation can occur, seizure, like I said, GI obstruction, cardiac and respiratory complications, and superior vena cava can be affected as well, which are all not good. All right. Before we go to laryngeal cancer, do we have any other questions? Do I have any other questions? Let me get to my peeps over here. Any questions? Okay. So, okay, so to recap on this, when you're taking care of someone with chemo, okay, you're not only looking at the labs, and you have to be looking at the labs, okay? You're monitoring their labs just like you would do, hopefully, with any of your patients, okay? You're assessing for GI complications, you're assessing for bleeding, you're assessing for fever, right? Okay? And any other signs and symptoms that may occur. With your craniotomy, you're going to be carrying out the orders, strict glucose control, the blood pressure you're going to be watching, right? You're going to be applying the cool compresses or ice packs if they're having pain, okay? And you want to assess to make sure that they're out of pain, okay? Why don't we take a 10-minute break? What time is it? 9:15. Why don't we come back at about 9:25 and we'll continue, okay? Any other questions? Okay, I'll see you in 10 minutes.
Celeste. Just wanted to let you know that did you deactivate the chat component?
No.
That's weird because it's nowhere to be found. I was trying to send a message to one of the students and I can't find it. I was just asking, I don't know how that happened, that it's not available, but it's not. So in case you were wanting students to send you messages via the chat, it's not.
No, I don't usually. That's why I ask them if they have any questions, because reading chat sometimes is distracting. But let me see. I can open it. Let me see.
Well, no. I sent it. It happened to be my advisee, so I sent her a text anyway. So.
Okay, but that shouldn't be off.
I know. I don't even know how you would. Remember, we tried to deactivate it at one time. We were trying to figure out how to do that, and I don't think we ever did.
When
I don't know.
Messages in a channel start at the first read. Okay, it looks like it's on. Who knows? Who knows with this thing?
I know. So if you you must have put us as co-hosts. So as a co-host.
Yeah.
As a co-host, there's a lot of capabilities I have, but one of them is not being able to send a doggone chat message, which I find very bizarre.
And it's funny to say that because I don't see my chat on my bar. You know how?
Yeah.
I don't.
Yeah, it's MIA. Oh well.
God knows.
That's okay.
I'll look.
That's all right.
But I
no big deal.
Questions and as long as they ask questions.
Can you hear me, Celeste?
Yes. Is that Veronica? Hey, V.
Hey. Zoom acting crazy today.
Yes.
Yeah. I'll call you and tell you what happened.
Okay. Yeah, there's an echo right there. Okay. Yeah, that's weird, Sheree. I don't know. Huh.
You hear how Veronica's reverbing?
Yeah.
I know.
Why is that? Do you know?
I don't know if there's some kind of, if maybe sometimes when you've got a lot of electronics on at the same time, it'll do that.
Yeah.
But anyway, I think what one of the students was saying when you were asking about the white cell count, and you were saying what's a problem, and when they're getting chemo, and they said low, which chemo is going to drop it. You were wanting for them to say, hey, a high white count when you're immunocompromised is definitely a sign of infection. But right. I think, because I heard the question too, and I'm like, well, yeah, no, low's a problem, but low is expected when you're giving them chemo because it's wiping out everything. So for that student, that was the clarification.
I'll reiterate.
Spit it out, sister. Spit it out.
Reiterate it.
Celeste.
Yes.
Okay. somehow Zoom signed me on the same computer twice because I text Cherie. I said, Cherie, my camera's on, but it's not picking up. Then I realized I was actually on double
That's what it was.
on the same computer. So I was about to leave altogether and then re-sign
Well, I'm
back
glad
on.
that you didn't.
No, and so when I came back, I was still on. So I said, well, okay, so I don't know. It wouldn't even let me sign on this morning. It kept telling me I wasn't signed in. It was really unusual this morning. And it
Yeah.
could just be my computer. I don't know.
You know, every time I lecture, I hold my breath and hope that it, it works. You know, it's like, please let it work. Please let it work. You know, I know.
I got you. All right.
Yes. Oh, did you see the thing, you know, that Teresa said about the burglar getting caught? The student was on Zoom for class, and the teacher, they saw in the background, the teacher called 911.
I didn't read it yet. I saw she sent us an email.
Yeah, that's what that is. Isn't that hysterical? Yeah, you can't hide on Zoom if they got the cameras on.
That's right.
Lord, it's going by so fast. Now wait, Monday we're having our 50 first 50, right?
I guess.
And then FABM behind that. I know I'm trying to squeeze. Advising in between. But you know, the regular ones, the ones that are coming back, they wait to the last minute.
Oh well. I did remind my students that even though they're in the last semester, still touch base with your advisor. My advice to my advisees in fourth level is graduate. And check your holds.
Wait, I was talking to my clinical group the other day, and I said, you know, who wants to review their test? And so they said, you know, so I'm looking at my calendar, so because I usually do like on Thursday and Friday after class. I'm like, wait a minute, I'm lecturing Thursday, I'm lecturing Friday. I said, okay, how about Monday? And so then Monday we have, you know, the test preview and FABM. So then I said, and then Tuesday and Wednesday's clinical, because I don't like to do after clinical, I'm so tired. And so, well, how about Thursday? Thursday I'm lecturing, and Friday is the test. I'm like, Jesus. I said, so I came home and did it after clinical on Tuesday and Wednesday. But it's like, oh my God, next week is already the test. You know, boy.
I know. Nina, I'm gonna send you a
right. I'll be right.
Invite, Nina. Okay, for 11:15, right? Okay. Hello, Nicole.
What you doing, Mama?
Nothing.
Miss John has us now.
I know you're her problem now.
She's so blessed.
She's your problem or whatever it is. Same thing.
Miss John, stop laughing.
And Kaylee, look, Kaylee's dog wants her treats. Oh, is that like a Russell? It looks like a Jack Russell mix.
I don't know what she is. She's part terrier, part chihuahua.
It's Jack Russell Terrier. You can tell it in the face. Is she crazy?
Not too crazy.
Oh, well then that's interesting because Jack Russells are like hyper like my dog, only they're smaller. Probably.
Yeah, she's 14 weeks old, so.
Oh, look at that baby. Oh yeah, she's got the Chihuahua eyes, but she's got the face of the terrier.
Yeah, she's cute.
Yeah. Where's Ma?
I have somebody being very cooperative this morning.
I see that, Tangy. I see that.
I'm happy. He looking at the screen like, who are those people?
He's like, just feed me.
Is that your baby?
Can you hold them up?
Hold them
Hold them
down.
up. Oh,
Say
look
hi.
at that. And
Say hi.
look at all that hair. Jesus, she must have had heartburn like crazy.
Yeah. See, I'm being
That's-
corporate this morning. Usually she's
Good.
screaming.
And he's
I'm
learning
like,
about brain tumors. Morning, Ebony.
Good morning, Miss Wiggins. I couldn't get my video on earlier, so I waited till
Oh.
break.
That's all right. I know you're there. Miss Shawn knows you're there. You're always there. You're doing what you're supposed. Shawnice looks like she's in San Francisco. Well, at least you're not in that loud. I don't know how you had your earphones on. Yes, I don't know how you can sit.
And
My
when I looked up,
God.
I was sitting right by the speaker. So
Oh my God. It's a good thing you had the earphones on because I was like, how can anybody study with that screaming ass rock and roll going on?
All right, looks like everybody's back, maybe, I guess. Yeah, okay. All right. Let me go to my share. All right. So let's keep moving along here. All right. All right, so now we're going to talk about laryngeal cancer. If I can get my little screen to work here. All right. So laryngeal cancer comprises half of all neck and head and neck cancers, okay? Usually squamous cell carcinoma is the most prevalent, all right? The most common sign and symptom is a sore throat, okay? So that doesn't mean like, you know, when you go to the Saints game and you're screaming and carrying on and you have a sore throat. It's a sore throat that doesn't go away, okay? Other signs and symptoms are maybe ear pain and hoarseness, coughing, persistent coughing, pain with swallowing, dyspnea, and a lump or mass in the neck. Okay? Of course, the risk factors are smoking and excessive alcohol consumption, and those stand alone are enough, but when smoking and alcohol together make it twice as risky. Unfortunately, African American males greater than 60 are at higher risk. Okay. All right. So usually with laryngeal carcinoma, hoarseness or voice change is another common early sign that their voice starts to change. Stridor is usually your later sign seen with this type of cancer. Okay, like I said, smoking plus alcohol increases the risk even more. Any issue above the glottis as far as the cancer will pose asthma concerns. Excuse me. All right. Usually cancer affecting the larynx is always a primary tumor. Okay. So usually a laryngectomy will be done, but it depends on the site and the stage of the cancer. Okay. If sometimes, like I said, if it's really advanced, they may do what they call head and neck surgery. Okay. And in this case, they will take not only the muscle tissue from the neck, but also the shoulder and the arm will be affected because they're taking muscle tissue, okay? So they will have weakness in the arm, okay, and they'll have weakness in the neck as well, okay? Radiation combined with chemotherapy is the most effective. There's usually two types of common chemotherapies that they'll use. And I'm just going to briefly tell you about these. I'm sure you'll probably hear of them. One of them is F5U, and the FU stands for fluorouracil. Okay, that's the most common one of the most common chemos that they'll use. And the most common side effect with this is stomatitis, mucositis, esophagitis, nausea and vomiting, and diarrhea. Okay, so when usually the symptoms will start to occur for 7 to 10 days post chemo. Okay, when it's initiated. Okay, if they start having nausea and vomiting, and they'll be on ondansetron and all that, but if their nausea and vomiting starts and it's not stopping, or it's persistent, they need to let the oncologist know immediately, because they can get into trouble real quickly. Okay. Also, if they start having chest pain, like if they go for outpatient chemo treatments and they go home, they start having nausea and vomiting, or diarrhea, or if they start having chest pain, they need to call 911. Cisplatin is the other chemotherapy drug that they use. It's an alkylating agent, and the most common side effect with this is nausea and vomiting, diarrhea. Okay, cisplatin also is commonly known for causing neuropathies, especially in the hands and the feet. Okay, these patients will experience xerostoma and stomatitis. Okay, so like we talked about before, you may teach them to rinse with their mouth with warm salt water and baking soda to soothe the mucosa, and maybe also some Biotine mouthwash to help to keep their mouth moist. These people will need multidisciplinary care, social services, speech, physical, and occupational and respiratory therapy, and a dietitian. They need to stay hydrated. They'll be neutropenic, so you need to teach them to avoid infections. Okay? Most of these patients that have surgery will have a tracheotomy. Okay, so they're going to have a tracheostomy. So I am not going to go into how to take care of a tracheostomy care. You need to go look into your review, your clinical skills book and review. Okay, you need to keep the airway patent, and it has to be humidified air. Okay, once they go home, they'll probably recommend that they have a bedside humidifier at home. Okay, while they're in the hospital, of course, you're going to have to be checking for their level of consciousness, just like you would any other cancer patient. Okay, these patients will be NPO. Okay, so they'll have enteral feedings. They may have TPN, depending on how emaciated they are. A lot of them will have PEG tubes. Okay. Stoma care. I'm hoping that you do know how to do stoma care from your being checked off for your trach care. To keep the area clean and dry. You want to teach them not to get any water inside of that. So how would these people, once they get home, okay, how would they clean themselves? Can they take a bath? Well, they can take a bath if they just sit in water. Can they take a shower? Yes. But they have to turn their back to the shower head. Okay? They need to cover that stoma, okay, because you don't want any water, because some people don't like baths, okay? So you can't tell them not to shower, but you would teach them to turn their back to the shower head, okay? Trach care and suctioning, Q4 and PRN are extremely important, okay? So that's when they're in the hospital, you will be suctioning these people quite frequently, especially right after surgery. They'll have a lot of mucus and drainage from the surgery. So respiratory therapy comes in, and they do their respiratory treatments when they're making rounds. But in between that, you're going to be responsible for taking care of these patients and suctioning them. Okay, just like any other patient that you may have had with a trach. And I can tell you, come wintertime, that first cold snap, all your little trach patients are going to be coming in with respiratory problems, asthma, and all that, because that cold exacerbates it. So when you're suctioning, FYI, stand back because they'll cough and they'll cough mucus out, okay? So post-op, these people are going to have a lot of mucus and you're going to be suctioning them a lot, okay? You need to teach them to support their head when they're moving, okay? Their neck is going to be weak, okay? So you want to suction them frequently. You want to support their head while they're moving, okay? They're going to have communication aids at first, okay? Now, ST, they'll probably be evaluated by ST immediately, okay? All right, because at some point the PEG tube will be removed and they'll go home and okay, but once the PEG tube have you ever had a patient with a PEG tube that also gets a tray? Has anybody had a PEG tube patient? Because most PEG tube patients, a lot of times why patients have PEG tubes is because they've had a stroke or something and they can no longer swallow, okay? But in some instances, patients will have PEG tube because they're not eating. It's not that they can't swallow, but they're not eating enough, so they give them a PEG tube for nutritional support. So you'll see them with the tray, okay? But in these patients with a laryngectomy, they're going to have issues with swallowing. So once they start to have PO feedings, everything must be thickened, okay? So if you have oral medications, like oral liquids, okay, so you have a little cup like this of maybe 2 mils, which isn't a lot, right, of oral liquid for them to swallow, okay? Just don't think, well, it's just like saliva, you just stick it in their mouth, okay? Anything that's going down that throat needs to be thickened, okay? And a lot of times, well, they'll have thickener packets. When when speech therapy evaluates these patients, they will have rigid orders, okay? They'll say, use the thickener to thicken the liquids to a honey consistency. They'll have strict guidelines on how to feed these patients with thickener, okay? How do you think these patients are going to be positioned when you're feeding them? What position? Come on, somebody tell me.
High phallus.
High phallus, 90 degrees if they can tolerate it, okay? Because they're at high risk for aspiration, okay? You might even teach them how to do a little chin tuck, okay? But they're definitely they definitely are at high risk for aspiration, okay? All right. You can have a stoma without a trach. Sometimes that does happen, okay? These patients are going to be neck breathers, okay? So if they're neck breathers and you have to perform CPR, how are you going to give them breaths? Where are you going to give them breaths?
Neck.
Via the stoma, okay? All right, not by mouth, but via the stoma. Okay, ventilation through the stoma. Okay. All right, like I said, they're going to be coughing out secretions, so stand back. All right. All right, let's talk about skin cancer. I had them laughing yesterday, okay? When I tell this to my students every semester, when you are doing your assessment, it is not a head-to-toe assessment. It is a head-to-toe, front-to-back. I'm going to tell you a little story, okay? I'm going to tell you a story about a nurse on our floor, Derek, and he'll tell you. He heard me talking to my students about how important it is to do a head-to-toe, front-to-back. And I said, first of all, I said, when you're at home, can you see your own hiney? Not unless you're standing in a mirror, right? Unless your head can turn 360 degrees, okay? So, Derek had a patient like me or Miss Wiggins or Miss Yon, a walkie-talkie, like if I went in and let's say I went in because my blood pressure was a little high. I'm independent. I get up, I go to the bathroom. Okay. So Derek had this patient that was independent, and so he went in, and he's an excellent nurse. Okay. But this is how you learn from your mistakes. So he went in, did his little assessment, talked to her, gave her medicines, and he walked out. A little while later, he came in, and while he was in the room, the doctor came in the room. The doctor's talking to the patient, and the doctor says, "Well, Miss Smith, how's that stage 2 wound on your backside?" Well, Derek was mortified because Derek didn't even know the patient had a stage 2 on their backside because the patient's independent. He didn't think it was necessary to look at that backside. Okay? So, FYI, look at the hiney. Okay? You are protecting these patients. You are your patient's advocate. If a patient has a melanoma or an unusual looking mole on their back they can't see, this is part of your assessment. Okay? Say, hey, you might want to look at a dermatologist for this. Okay? You are their protection. Okay? All right, so let me go back to my, so that's my little soapbox lecture for today. Look at their hiney. All right, and look in between their toes, okay? All right, so sun exposure. All right, sun exposure, we know that is the leading cause. Tanning beds for all the young little ladies and gentlemen that think that they can go get a great golden tan and not get cancer, they're dead wrong, okay? Age, skin type, skin color, genetic predisposition all play a part. My mother had skin cancer, both my brothers had skin cancer, and I have had skin cancer. By the way, I didn't know this until I had skin cancer, but the type of surgery that they do is called Mohs surgery. So if you ever hear the word Mohs surgery, that's for when they're removing skin cancer. They usually like plastic surgeons that do the type of surgery, okay? Can African Americans get sunburn? Yeah, absolutely. Shanice said yes, okay. And even if they're extremely dark, they get burned, okay. They need sunscreen just as much as little pale face here is, okay. I'm blonde hair, blue eyes, okay. I'm susceptible, okay. But yes, so you need to instruct all of your patients how important it is to use sunscreen. And now it's they make all kinds of sunscreens that are not only the zinc oxide that the lifeguards wear, that white stuff over their nose. Okay, zinc gives you 100% block. Period. It blocks out everything. Now they're making clear zinc sunscreen, so you can put it on. It's a little bit heavier, but you can put it on your face, on your skin. So they're making some good products out there. Okay. Single blistering burn during childhood, okay, it can predispose the child for later risk of developing melanoma. Okay, that's why. And I'll tell you another a funny story. Miss Hopkins and I were laughing at. When I was young, when I was in my teens and early 20s, and of course they didn't know any better back then, I used to get my little towel, okay, go out in my backyard and put baby oil and Crisco oil on my skin and fry myself like a little popcorn kernel, okay? We did that back then. Miss Hopkins was laughing. She said, "Oh yeah, I did too." She said she put iodine in hers.
Yep, iodine.
Iodine, okay. Miss Wiggins can attest to this. With baby oil and Crisco oil. And of course my mom would go, "Okay, honey." They didn't know any different, okay? So we're out there cooking ourselves, okay? No wonder I got skin cancer today, okay? So, and of course, today's a lot different. A lot more people, a lot more educated now. But, I mean, I can't tell you how many blistering sunburns I've had in my lifetime. Environmental factors.
Dr. Phillips.
Yes, ma'am.
And my little take on all of this sun issue, I didn't realize until I was in the water all day as a teenager. I'm swimming all day. I'm black. I don't get sunburned. Was I ever sunburned? Oh my God. So from the other side, I just thought I was a superhero. You know, I can go out there.
But you know, even today, Ms. Jean, it's a big misconception for African Americans that they can't burn, but they can. My youngest son has olive complexion, so you know he can go out in 5 minutes and come back brown. Okay, and you know, he doesn't burn as quickly as I do, but I'm constantly telling put sunscreen on because it makes me crazy. But yeah, so that's a big misconception, absolutely, and you can attest to that too. Yeah, and swimming too. People don't think, well, you know, I'm in the water, so I can't get sunburned. Wrong. Ooh, you learn your lesson the hard way, don't you? Okay, so UVA, your sunglasses. When you go buy new sunglasses, just don't look and see if they're UV protection. It's got to be UVA, UVB. You can get cancer of the eye from the sun. Okay, you can also get glaucoma and cataracts. Okay. Pollutants in chemicals, ionizing radiation, viruses, physical trauma can all cause skin cancer. Okay, so let me see if I can get this to advance. Hold on. Why can't I get this to advance? Let's see. Don't you just love? All right, come on. Let me get this to advance. There we go. Okay. All right. So, let me move this to where I can. Okay. Sun safe practice. Now my slide says avoid the sun from 11 to 3. Well, that's fine and dandy if you live up north. We live down south, so I would change that from 10 to 4. Okay. Where do we live? We live down south. We have more sun exposure than people up north. Okay. I can tell you, I mow my own lawn, and in the summertime at 9 o'clock, that sun is hot and beaten down. Okay. So you want to avoid the sun, if at all possible, between 10 and 4. Okay. Daily use of sunscreen, SPF of greater than 15. Preferred is 30 or better. I say 50 to 100 myself, but you know, at least 30 or higher. You have to apply this 30 minutes before you go out in the sun because you need to give it time to absorb into your skin. Okay. You know, they make all those sunscreens now that are sweat resistant and water resistant. I don't care what they are, okay? You need to reapply them Q2 hours because I can tell you, just from mowing my lawn and working out in the yard, within an hour, I'm sweating all that stuff off, okay? So reapply frequently. Light colored clothing, hats, long sleeve, and sunglasses, okay? They're making even clothing now with the UV protection built in. They're making all kinds of good stuff now. You see the little popcorn kernels up there? That was me and Miss Hopkins out there laying down, getting burnt from Crisco oil. Okay. All right. There's two types of skin cancers. There's malignant and non-malignant. Okay, your melanoma is malignant. Okay, you can get melanoma where the sun don't shine. And I was talking to my students about this yesterday. If you go to a dermatologist, and I recommend that everyone does, okay, get a head-to-toe assessment. A good head-to-toe assessment from a dermatologist means they start at the scalp, okay? They start at the scalp. She will look at my scalp. She'll start all the way down. She'll look at my fingernails. She will look in my inguinal area. She will look at my labia. There's certain type of skin cancers that look like a rash in the genital area, and you can get them in your butt cracks. She looks in between my butt cracks. Okay, so you can get melanomas where the sun don't shine. Okay, so it's important, especially if you have a family history of cancer or you have a lot of moles on your body. It's a good thing to get a head-to-toe assessment once a year. Okay. Okay, so melanoma arises from the term melanocytes, which is basically the pigment in the skin. Okay. All right, so there's precursors to skin cancer, and this is just a little FYI. I'm not gonna test you on this, but just know that some of the precursors are congenital nevi, which is these are moles that children are born with. Okay, there's a dysplastic nevi. These are atypical moles. These are normal moles during childhood that have a greater increase of abnormal development once they hit puberty. Okay, puberty just makes everything go rampant. So if you have a child that has moles, you know, don't panic, just watch them. But as they hit puberty, you want to be more cognitive of looking at that. Okay, you've got your lentigo maligna. Okay, this is also called the Hutchinson's freckle, if you ever hear that term. It's a tan or black patch that looks like a freckle, okay? And it's usually on one side of the face. It's usually with older adults that have been exposed to this, to the sun a lot, like if they work outside. And eventually, the moles will get darker and thicker and more nodular, okay? So, let's see. Okay, so you see that little lady in the middle, the lentigo maligna melanoma, you see how it's on one side? She's been out in the sun a lot, and I've seen this in people before, okay? And it starts out as just like a little mole, and then it progressively gets thicker and nodular, okay? Up here, let me move my screen, okay? Up here is, you see that acrolentiginous, okay? That's skin cancer. It's very rare, but it's skin cancer that forms underneath either the soles of the feet or the plantar or underneath the nail beds, okay? So if you look at the picture on the left, it looks like he smashed his finger in the doorway, but that's actual skin cancer, okay? Then you see the stripe right there that is cancerous too. Down here by the heel, if you look at that, that kind of looks like a blood blister. I know someone that had that, and they biopsied it, okay? And it was skin cancer. So these are just different types of moles, okay? All right. You see how to the left, this one right here, you see how it starts to get thick and nodular, okay? That's not a good sign. All right. So this is important. This is your A, B, C, D, and E. This is how you would assess moles on your patients, okay, or anybody else. All right, so A stands for asymmetry. You see how this is just a regular flat mole, okay, looks like an everyday mole. It starts to get suspect when it starts to become asymmetrical, okay, so you want to watch for that. Your B is your border. The borders are pretty regular right here, but if they start to spread out, okay, that's suspect. Your C is your color. Like I said with the lentigo maligna, okay, it starts off as maybe a light brown, and then it starts to get darker and maybe more nodular. That's suspect. Your D is your diameter. Once they start getting 6 millimeters or greater, that's definitely suspect, okay? And then you're evolving where it starts small and starts to get bigger. The one I had, was just like a little red dot, okay? But it didn't go away, and I thought, this doesn't look good. And of course, it was fortunately basal cell. But so you would want to teach these people to stay out the sun, long sleeve hats, right? You're going to be checking these patients from. In fact, I was with my student one day, and we had a walkie-talkie patient, I call him. He was sitting up on the side of the bed. It was an African-American male. And we were going through, and sometimes your patients, they don't, you don't have to do that. You don't have to look at all that, but you do, and you tell them, I have to do this, okay? And you explain to them why. So we explain, that we have to look them over because, we are his eyes for things he can't see, like moles on the back or, And so he was very appreciative. And then he told my student, he said, "You're the first person that's ever done that. Don't be that nurse." Okay. Pretty sad. He's been there for a long time, in and out, and nobody's ever looked at him thoroughly. Okay. And Derek can attest to that because Derek got caught and he was like, "I learned my lesson." So, I don't say these things just to hear myself talk. If you want to be the best nurse you can be, like somebody with diabetes, you don't just look at, for swelling in the feet and their toenails. You gotta spread those toes apart. Real quick, I had a patient. Okay. I had this patient years ago when I was in nursing, and I did home health on the side. And at my hospital, we were one of the first hospitals that did the wound vac. So the home health agency I worked with knew that I knew about wound vacs. So it was on a Sunday, and I can even remember where this patient lived. They asked me to go out to see this patient who had a wound vac, and it was I had to troubleshoot it because it wasn't working. And she was a young lady in her early 30s. So it was summertime, and so I went to her house, and she was sitting underneath her carport. And so here was her foot right here. So she was missing her great toe and this toe. Okay, so her wound was all here. Okay, so the wound vac was covering this part of her foot. Okay, so I'm talking to her while I'm fixing the wound vac and putting it back on her and stuff. And so I said, how did you lose your toes? Now, never even occurred to me. Okay, where do we live? We live down south. You know what my summer uniform is? Trust me when I tell you. My t-shirt, shorts, and flip-flops. Okay, when I'm retired, that's all you're going to see me in. Okay, unless it's cold and I'll have longer pants on. Okay. She's a young girl living down in Louisiana. What does she wear? Flip-flops. Because she had diabetes and peripheral neuropathy, she didn't feel that plastic cutting into her toes. Okay, and apparently nobody ever taught her. That's why I'm always saying you got to look between those toes. She lost both. I mean, it was a big wound. She lost like almost half of her foot, and I was hoping that they could save it so she could at least keep her foot. And I was like, whoa, this is the importance of checking between the toes and teaching them because, and this is part of your job. So it's not just checking for edema, checking the nail beds and the heels. You got to check between those toes, and it's head to toe, front to back. Okay. So let's recap real quick. Any questions so far? Anybody have any questions? Okay. So let's go back and recap real quick with your brain tumors. Okay. When you're assessing these patients post craniotomy, okay, what are you monitoring them for? What are you monitoring? So you have a patient that's post craniotomy. Okay. How are you going to take care of them for that day? Somebody tell me.
Assessing for drainage to make sure they don't have a CFD.
Yes. Okay. You're going to assess the incisional site too. Okay. Take care of that. You may even be putting a little antibiotic ointment on that. And if it's painful, you can put cold. What type of pain medication might you give these people?
Morphine, short acting.
Absolutely. Okay. What about, tell me about the vital signs. What are you assessing for? What are you monitoring?
Signs of infection, elevated fever.
Okay. What about their blood?
And hypotension.
Yes. Okay. What about their glucose?
They're on steroids, so you want to monitor that as well.
Yeah. And like I said, strict glucose control. These people are not just like your little ackies. You really, and of course, these patients are going to be in ICU. So, everything in ICU is a little bit more magnified than it is on the floor. Okay. But that's things that you have to remember. I have to do this. I have to do this. Okay. A transpenoidal patient. Okay. What are you teaching them?
Don't sneeze.
Not the cough, not the sneeze.
Okay, and you're assessing for CSF fluid, okay, and even if it's a craniotomy, transpenoidal for sure with the nose drainage, but ear drainage, any kind of drainage that's coming from where it's not supposed to be is like a cardinal sign, you better be looking at them. Assessing them for what? Meningitis, possible brain abscess. If they have a drain, you're not going to put it to suction, are you? You'll be draining the brain. Okay, positioning these patients. How are you going to position them?
At a bed elevated 30 degrees.
Yeah. Right. And this just really ties in with Miss Wiggins' lecture. You know, I mean, they go hand in hand. It's intracranial pressure. So you're going to be doing the same things, okay? But your patient has a different diagnosis, but you're assessing them for the same things, okay? And you're taking care of them the same way as far as the head of the bed and what you're assessing them for, fever. You don't want their sugars to go too high. Fever can raise the temp. They're not going to be. What type of fluids are they going to be on?
Hypo or isotonic?
Isotonic or hypertonic.
Yes, depending on what's going on with that patient. Okay. All right. So, okay. So let's talk about laryngeal cancer. Oh no, let's go back. All right, let's talk about chemotherapy. Okay. So what labs are you monitoring with chemotherapy and radiation patients?
White blood count.
Okay. Tell me about the white blood count.
It's expected to be low.
Okay, it's expected to be low. Okay, it's expected to be low because they're immunosuppressed. But if it starts to rise, then that's okay. So yeah, you would expect them to be on the low side because they're immunosuppressed. But if you have a patient who's all of a sudden, you know, they take they draw their labs like maybe every Q12 or 24 hours, and that WBC goes, 8,000 to all of a sudden 15,000. Houston, we have a problem, correct? But you're absolutely right, Ashley. You would expect it to see low because they're immunosuppressed, but when it starts to rise, there's a problem. Okay, what about the platelets, high or low?
Low.
Okay, yes. If the platelets start to drop, that's a problem. Okay, the H&H is going to be low. The RBCs are going to be low. Protein's going to be low. Albumin's going to be low. Okay, but especially when they're having chemotherapy and they've had it and they start getting nausea, and they start vomiting and stuff, or they just don't feel like eating. Yeah, you got to monitor those protein levels, and you might want to get them some supplements on board, as far as protein supplements. You can put it over ice and have a sip on it. What kind of foods are you going to be giving these patients?
Cold, bland, and soft.
Yes, bland and soft, maybe some cold foods. You might want a little warm soup. Okay, whatever makes them comfortable. Okay.
Nothing spicy.
What?
Nothing spicy.
Nothing spicy. No. No, they won't. They'll probably look at you like you're crazy anyway if you do that. But you want to make sure that if it's some food that somebody's bringing in, you need to make sure that they haven't spiced it up from home. But you got to monitor all that. But hopefully nobody's bringing anything in. But sometimes they'll sneak some stuff up. So those tricky little family members. Okay. And of course, with any patient, you're going to assess for the airway and the breathing. Okay. To make sure that if they have a laryngectomy, okay. All right. How are you going to give them oxygen? How are they getting oxygen? Just regular oxygen.
Through the stomach, through the neck. Or through the mouth.
But I mean, it's called an O2 trach collar. You've seen that cuff over them. Okay. It's called a trach collar. Okay. That's how they deliver oxygen. And by the way, FYI, if you're taking care of a trach patient for any reason, and they're coughing and stuff, and they need to be suctioned. Two things that are my pet peeves, okay? You have a Yanker suction that you can suction around the site, okay? Okay. Please do not, and you see it all the time, they'll take the Yanker suction and they'll put it in the sleeve and hang it over, and you go to use it, and it's green with gunk, okay? That sticky mucus, pitch it. Get another, or you'll walk in and you'll see it on the floor. Do you want something that's on the floor going in your mouth or anywhere else? Okay, pitch it and get another one. The trach collar, okay? They're going to be coughing and everything else. When you go to the trach care, or if you're just in the room taking care of the patient, take a 4x4 and wipe it out, please. Please, please, please. It's a source of infection. Mucus holds on to all that bacteria. Okay, that's my two little pet peeves. That's my little soapbox, okay? All right. Let's talk about, okay, so of course they're going to be on DVT prophylaxis, okay, prior to a craniotomy or surgery, any type of surgery, craniotomy or laryngectomy, okay. They're going to be on corticosteroids, and they're going to be doing either CT or an MRI, okay. So if they get an MRI done, what do you need to check for?
Allergies.
And metal.
And metal, and some tattoos sometimes, depending on the tattoo. Yeah, so you want to check that, just like you've had this already from other lectures, okay? And yeah, if they get an MRI with contrast, you need to make sure they're not allergic to iodine, right? Okay. GI, tell me about the GI. What are you doing for them?
They're more prone to ulcers, right?
Yes, they're more prone. So what do you expect to see in their medication profile? What do you expect?
PPIs. Antipsychotics.
A PPI or H2 blocker, right? Okay. What are you going to be assessing as the nurse, GI wise?
Bowel sounds.
Bowel sounds. And I guarantee you, if you look at Ash, is that your little girl? If you are not assessing 4 quadrants, baby, you're going to end up in a court of law, okay? And you have to chart it. And if you can't hear it in one quadrant, you get another nurse to help you listen, okay? Because these people can get into trouble real quick. Because they're not as hydrated as they usually are. They have hydration problems. B, they're on pain medication, okay, which is gonna constipate them, okay. They're on all these other types of drugs, antibiotics, steroids, okay, that is going to affect the GI, okay. So you need to make sure that they're having bowel movements on a regular basis, okay, because they got enough problems. They don't need to be getting a small bowel colectomy, okay, because you didn't do your job, okay. All right, and then let's see. All right, let's talk about real quick. Somebody's on chemotherapy, okay, and they come in as an outpatient, and you're working oncology, okay, and you put an IV in them because they don't have a porta-cap. What are you assessing?
The IV access, make sure it's paid and it flushes well.
Okay. All right, and then you start the chemotherapies. Now what?
You're going to assess everything. Make sure
30, 60 minutes, okay, to make sure that peripheral site's patent and they're not having any issues, okay. What are you giving these patients as far as oral care?
No alcohol-based mouthwash.
Right, and you might want to give them some biotin or suggest that they get biotin when they get home to help with the moisture in the mouth, okay. You want to make sure that their O2 sats are 94% or greater, right? So whether they're having a craniotomy or a laryngectomy, okay, O2 airway, so it's 94%. If their temp is 100.4, just like COVID, COVID, that's what, 100.4, you need to look at that, okay? All right. All right, so somebody's got a laryngectomy, okay, and so they're NPO, all right. Just a little FYI, I came across, well, I heard about it. A nurse, she won one of our graduates. Thank goodness. Okay. I don't know where she graduated from. I don't know how she got out of school. Okay. Freshly out. Okay. Don't be that nurse that goes in and I got this. I know this. I know everything. Okay. That's a dangerous little habit to get into because you don't. I'm 65 years old and I still don't know everything. Okay. So this nurse goes in. I don't know what kind of report she got. Okay. But you don't always get the best reports. So this is your report right here. This and listen to the patient, okay? So she walks in the room to go give the patient's meds. I guess they told her to report the patient's meds need to be crushed, okay? I guess that she got that report. So she goes in, patient has a peg tube, okay? Now, I don't think that there was anything going through the peg tube. It was probably bolus feedings or whatever, okay? She crushes meds and gives them orally. What's wrong with that picture? Patient has a peg tube. If you're not sure whether the patient can have anything by mouth or not, but if they have a peg tube, put it through the peg. You're safe, okay? Because yeah, they may be that type of patient that they have a peg tube for nutrition, but they get a tray. But if you don't know that, put it through the peg, okay? The patient was MPO because they had difficulty swallowing. Okay, if you're going to crush meds, you better know which ones can be crushed and which ones can't, because I guarantee if you crush the wrong blood pressure medication, you can put them into a heart block and kill them. Okay, so if you have a patient that has a peg tube and the meds need to be crushed, and you come across your extended release or your sustained release or whatever. Call the pharmacy and say, I need a different route. They have a peg tube, okay? And if they tell you, well, you got to call the doctor, then call the doctor, okay? But don't just assume, so I got reports, crushed meds, so that must mean that, you crush them and you put them orally, okay? So if they have a peg tube for a reason, okay? But once they begin to get oral intake, what are you going to make sure of?
Swallow.
Check the gag reflex.
Who said what?
Check the gag reflex.
Check the gag reflex. You betcha. And I tell my students all the time, especially if you have an elderly patient and you didn't get a good report. Okay, elderly patients to begin with lose their everything gets weak. Okay, so you want to sit them up, and I tell them before, and they can swallow meds. Okay, but you want to give them a little sip of water first. Sit them up, give them a little sip of water to see if they cough or just, okay, because they may be having some aspirin precautions, okay, and have them do the chin tuck, okay. So you're going to sit them up to 90 degrees, okay, and you're going to check to make sure you have a gag reflux, okay, and then you're going to use thickener, right? You're going to follow the the speech therapy's guidelines. And I don't care if it's 2 little milliliters of liquid, it still needs to be thickened, okay? All right, or you can put it in applesauce or whatever, but it's got to be thickened, okay? They cannot have any thin liquids. All right. Skin cancer. What you going to teach these people? Oh, and by the way, people that have been diagnosed with skin cancer, okay, especially melanomas, they will be going to see the dermatologist every 3 months for the first 2 years, and then every 6 months for the following 5 years, and then after that a year, okay, especially with melanomas, okay. So they're going frequently. You're not going to say, okay, well, you see your doctor again in a year. Okay, no. They'll be going more frequently.
Can you repeat that timeline one more time?
Well, I certainly can. Okay, so they'll be going every 3 months for the first 2 years. Okay. I'm not going to test you on this, but know that, okay? They, if they've been diagnosed with a melanoma, they're going to, and times are different now. Science is different now. There's a lot of people that can survive melanoma now. Okay, so if they've been treated with melanoma and they've gone through radiation and chemotherapy, once they're released and everything is done, they'll be seeing their dermatologist every 3 months for the first 2 years. Okay, that's a lot. Okay, but they're more prone to it. Then after that, they'll be going for every 6 months for the next year. Okay, and then after that, they'll do yearly checkups. And of course, it also will depend on the dermatologist. Okay, but usually that's the protocol. So, sometimes too, and when you have someone that comes in, okay, and you're doing your physical assessment, you want to take a history, okay? You're going to take a history on everybody, okay? But if they're coming in, you're going to get a history of, do you have any moles that have been suspicious? You're going to be looking at moles, you're going to be looking at warts, you're going to be looking at birthmarks. One of the cardinal signs, too, is a little FYI, you're not getting tested on this, is a birthmark that itches. Everybody has a lot of people have birthmarks, okay, and it's not. But sometimes a birthmark that itches can be a sign of something suspicious, okay. Or if there's a mole with a crust or it's bleeding, okay. Like I said, I had a little red dot. It didn't look like anything, okay, but it wasn't getting any better, okay. It's like a little red dot. So you want to get a good history from these patients. What's your family history? Do you have a family history of skin cancer? What type? Do you use a tanning bed? Do you work outside for a living? A few years back, I had a new roof put on it, and it was in late August. And those poor men on my roof, I kept buying them popsicles for all it was worth. They're working on that roof from like 8 o'clock in the morning to 7 o'clock at night with the heat bearing down on in August, okay? All I could think of was skin cancer, but so, and of course you want to teach prevention, okay? Any other questions? Now, I had one of my students ask me about the readings, okay? You've required book readings you need to read, okay? It's not a lot, but the articles are there for clarification and support. There's not a lot in your book on craniotomies, okay? That's why I pulled that article for you to look at, okay? But go through your notes, use the discussion board, okay? If you, like Ms. Jean says, if you're too shy to post anything on the discussion board, send your question to me and I will post it so everybody can learn from it, okay? Any other questions or concerns? All righty then. Y'all have a good weekend. Thank you for coming.